Good day, dear colleagues. Today our lecture is peripheral occlusive arterial diseases. Here you can see anatomy of the arterial supply to the lower limbs. And you can see how it goes from aorta to the iliac arteries, then common femoral artery, profunda femoris, superficial femoral artery, popliteal artery in the area of knee, and then it goes to the anterior tibial artery, peroneal artery, and posterior tibial artery on the ankle and foot, and then go to the arteria dorsalis pedis. Occlusive disease of the arteries, diseases conducing to the gradual narrowing and complete occlusions of road clearance of aorta and main arteries. Two basic diseases use this term: obliterating arteriosclerosis and obliterating endarteritis. Obliterating arteriosclerosis is a chronic disease characterized by lesion of arteries as local thickening in their wall of connective tissue with lipid infiltration of internal layers, conducing to stenosis of lumen of arteries. Death rate from arteriosclerosis is 40%, and the number of amputations of limbs 20% of the total number of patients with arteriosclerosis. Most men suffer after the age of 60 years. Here you can see a picture of atherosclerotic process inside of the vessels, and you can see narrow lumen with a plaque inside, and this plaque is the main blockage of the blood supply in the arteries. Atherosclerotic defeat of aorta. Obliterating endarteritis, a chronic inflammatory disease of the arteries with preferential involvement of the distal vessels of the upper and lower extremities, and the subsequent spread of the pathological process in the proximal area of the vascular system. Most men suffer under the age of 40 years. Here you can see differently diagnostic signs: obliterating atherosclerosis and obliterating endarteritis. Each for first is after 14, second under 40. Sex, male usually, in first and second. Disease course, gradual progression for the first, and undulating with the periods of remission and intensify for second. Extremity lesion, lower extremities, asymmetrical lesion for first, and for second is the lower and upper extremities symmetrical lesions. The nature of lesions. For the first affects the large arteries elastic type, and for second affects the medium range arteries muscle elastic type. The length of the lesion for the obliterating atherosclerosis is usually segmental or local. For obliterating endarteritis is usually diffuse, and arteriography results filling defect as a sign of plaque for first, and the contours of artery evenly narrowed for the second. Peripheral arterial disease, acute and chronic occlusion. Sudden onset pain followed by paresthesia and then loss of function, usually due to an embolus, usually at site of vessel bifurcation. Thrombus, clot is already present in the diseased vessel. Gradual onset. Long-standing symptoms of intermittent claudication. In atheromatous vessels, which were previously patent, a colorectal circulation will have been present. Chronic arterial occlusion. On this picture, you can see arterial thrombus in coronary artery. How it's looked. Risk factors for peripheral arterial disease. Diabetes mellitus, chronic smokers, hyperlipidemia, family history. Note: obesity also predisposes to atherosclerosis. Features of peripheral arterial disease. Common presenting symptoms: intermittent claudication, a deep-seated giant pain in the cavus bronch on by exercise, delivered by the rest in an early symptom. Paresthesia, rest pain, usually for late symptom. Gangrene and ulceration, also late symptom. Features of acute occlusion include pain, pallor, paresthesia, paralysis. On examination, you may expect to find decreased or absent peripheral pulse, arterial roots, decreased skin temperature, atrophy of extremity, dystrophic nail, hairless skin, ulceration, and gangrene. Physical examination. The weakening or absence of pulsation of the arteries, systolic sound, auscultation of the aorta and arteries. And here on this picture you can see how we palpate and at what points we palpate pulse. So usually it's the femoral artery, arteria popliteal, and arteria dorsalis pedis. Diagnostic. The ankle brachial index measures the ratio of the lower to upper extremity blood pressure. Is a significant predictor of cardiac events. Here you can see complications of the ischemic problems of the lower extremities, like edema, gangrene, ulcer, ischemic hyperemia. Claudication distance, an indication of severity. State classification of PAOD. So what is it? Stage 1 is an asymptomatic decreased pulse. ABI is less than 0.9. Distance 1000 meters. Stage 2, intermittent claudication, ABI 0.7, 0.9, distance 200, 1000 meters. Stage 3, daily rest pain, BP less than 50. Stage 4, focal tissue necrosis. PAOD is a peripheral arterial occlusive disease, ABI, ankle brachial index. Grading claudication. Initial claudication distance is the distance patient first experiences extensional pain. Absolute claudication distance versus distance patients is able to walk. Experts from the European countries came to the conclusion that it's appropriate to combine patients with third and fourth degrees of ischemia in one group, which they defined as patients with critical ischemia. The selection of these patients is necessary because they have higher risk of amputation. To avoid this, they need systemic hospital treatment with preventive aim. The number of patients with diseases of lower limbs arteries who already have critical ischemia reaches from 500 to 1000 people per 1 million population per year. In diabetes mellitus, critical ischemia occurs about 5 times more often. 90% of the lower limb amputations worldwide are performed indicated to critical ischemia. Instrumental diagnostic: Dopplerography, CT angiography, MR angiography, and simple angiography. Dopplerography is a hemodynamically significant stenosis of the vertebral artery. And you can see changes. What changes here can happen in this case. Also, in this picture, you can see one of investigation is angiography and MRI. And in the first picture is arterial thrombosis arch of aorta, and second NCT angiography. At the place of introduction of a contrast agent, injected directly in the test vessel. Indirect, injected into the arterial system to obtain venous and parenchymal phase of contrast, enhancement of the organ. By way of introduction of the contrast agent, puncture the injection directly through the needle puncture. The case suit the introduction of the catheter overall, semi-selective and selective. Here you can see pictures of angiography and its results. Here you can see areas of the blockage of the blood supply. Coronarocardiography is also contrast investigation of coronary arteries. And here you can see examples of the pictures with the problems of blood supply. You can see blockage of blood supply of the coronary artery. Leriche syndrome is a form of peripheral artery disease involving the blockage of the abdominal aorta and its transition into the common iliac arteries. Claudication of the buttocks and sinks, absent or decreased femoral pulse, erectile dysfunction. Takayasu disease is a form of large vessel granulomatosis vasculitis with massive intimal fibrosis and vascular narrowing, most commonly affecting often young or middle-aged women of Asian descent. So anyone can be affected. It mainly affects the aorta and its branches, as well as the pulmonary arteries. Females are about 8-9 times more likely to be affected than males. And here you can see angiography with Takayasu disease. Principles of treatment: risk factor modification, exercise program, antiplatelet agents, rare polyglycine, aspirin, clopidogrel solutions for intravenous and intramuscular injections, metabolic therapy like actovegin and sulfaceryl, vasopressin, alprostan. All these diseases is going to increase microcirculation and circulation of the blood at lower extremities. And from surgical treatment is a surgical revascularization like bypass methods and amputation. Treatment of coarctation. Supervised exercise training should be the initial treatment. 30-45 minute sessions, 3 or more times per week, at least 12 weeks. Value of unsupervised exercise programs is not well established. Also, we can give cilostazol 100 mg twice daily. It can improve symptoms and increase walking distance. Indicated for lifestyle limiting coarctation. Contraindicated in patients with heart failure. And also we can give pentaxiphyline 400 mg 3 daily. Considered as an alternative to cilostazol. Effectiveness of pentaxiphyline is marginal and not well established. Sympathectomy is one of the methods of surgical treatment. It can be thoracic sympathectomy and lumbar sympathectomy. How it's looking? Patient's position on the back. We enter to the thoracic cavity. We can use it laparoscopically. It's minimal invasive and very nice, very good, with minimal trauma. Enter between the ribs, find sympathetic nerves, and we blockage it, we clamping it and cut. Here you can see on this picture, intraoperational picture, inferior vena cava. It's a lumbar sympathectomy. Inferior vena cava, clip of the gangrenous upper end, lumbar gangrenous. You can see ganglion. Here is lymphatic vessels and psoas muscle. Reconstructive surgery. From these surgeries is enterectomy, patchplasty, open surgery, semi-closed and closed. And here you can see plasty of the vessels. We can use artificial materials for the plasty of the arteries and veins. And here you can see intraoperational picture with a vesoplasty with artificial material. Usually what we use during these operations, like artificial material, it's Gore-Tex. This is Gore-Tex. Also from reconstructive surgery, the vascular grafts, outer venous, we can use. So we use open vein of the patient. Usually it creates a venous vein or external jugular vein. And we can use synthetic implants, porous, corrugated, cardboard, braided cloth, and knit. And here you can see artificial materials. Treatment of peripheral arterial disease. Revascularization for femoropopliteal disease. Femoropopliteal bypass surgery. Primary patency at 5 years of 60-80%. Alter larger veins preferred to synthetic grafts. Perioperative mortality is usually 0 to 3%. Femoropopliteal angioplasty. Patency at 2 to 5 years ranges between 40-70%. Technical problems due to several anatomical issues, occlusions and stenosis, diffuse disease, a ductal canal disease in run of vessel. Perioperative mortality is very low. Revascularization for aorta-iliac arterial disease. Aorta-femoral bypass. Primary patency at 5 years of 81-85%. Perioperative mortality is 5-8%. Received for severe diffuse disease cases. Percutaneous intubations. Patency at 5 years of 65-80%. Perioperative mortality is 0.1%. Treatment of choices. Arterialization of the venous bed. Arterialization of the great saphenous vein according to the methods in situ. Here you can see an overview of new technologies. Amputation. A properly performed amputation can be life-saving for the patient, may often be a better therapeutic alternative than an ill-conceived frontal attempt at vascular reconstruction doomed to the fail for lack of adequate recipient vessel. Main goals of amputation surgery: preservation of functional length, durable coverage, preservation of useful sensation, prevention of symptomatic neuromas, prevention of adjacent joint contractures, controlled short-term morbidity, early prosthetic fitting when applicable, and early patient rehabilitation. Assessment of amputation level in ischemic lower limbs. Currently, there are no consistent criteria that can be applied before surgery. The main objective of amputation is removal of sufficient diseased, infected and gangrenous tissue to permit the stump of the how, but in the same time return adequate limb length for prosthetic fitting. The use of the scoring system depended the preoperative angiogram to assess the runoff vessel situation provides a practicable and direct way to help predict the level of amputation in ischemic lower extremity. However, it's not totally reliable and should be used as one of the factors to be considered when the amputation is required. Other invasive and non-invasive techniques can also be utilized in the assessment of circulation in determining amputation level preoperatively. Assessment during the operation of focal circulation is of extreme importance. And here you can see on the first picture above knee amputation. On the second picture you can see cleavage amputation, cylindrical amputation, cylindrical conical, normal conical, and pathological conical. Thank you very much for your attention. We finished. Wish you success. Goodbye.